Good morning, everyone, and welcome to Frankie Says Relax, the ins and outs of skeletal muscle relaxants. Your faculty this morning are Dr. Chris Herndon with Southern Illinois University and Dr. Mandy Mullins with the VA St. Louis Healthcare System. As a reminder, we will have three sponsored lunches today. One will be in Nolita up here. The other two will be downstairs in Breria and Castellana rooms, I believe. And I'll now turn everything over to Dr. Herndon.
Okay, thank you very much. Good morning. How are you all? Everybody full and ready for another go at it? Did you all appreciate the theme music matched to the title for us older people? Has anyone in here ever seen Frankie Goes to Hollywood in concert? One hand. Oh. Well, we're not naming names here. Well, anyway, welcome. We're going to be talking about skeletal muscle relaxants this morning. Hopefully our talk does not have the same sedative properties that a lot of these agents have. We do have some disclosures and some learning objectives that we're going to try to cover. We have a lot of things that we're going to try to get through, and as always, our definition of a good talk is if we have you leaving with more questions than you came in with, so that's going to be our goal for this morning. Hopefully we can do real quickly really quick neurophysiology refresher, just so some of the pharmacology around the drugs might make a little bit more sense in terms of not what it says in the package insert per se, but some of the newer data that's coming out with these agents about how they may actually exert the effects that we think that they exert. We have a number of different types of nerves, okay, or neurons. And of those, I think that the best way to categorize these is based on sensory, motor, and pyramidal neurons. And then each have their own cells and projections that go along with that. We're going to focus on motor neuron and the associated sensory neurons this morning. It's really interesting in that we have upper motor neurons that have been really well defined, and then we have lower motor neurons. The upper motor neurons tend to synapse at inhibitory interneurons within the CNS. The lower motor neurons tend to be involved with synapsing directly with some of the muscle bodies, the intrafusal cells, and then also they can synapse with positional cells as well regarding the muscle. So there are a number of different types when we talk about the actual motor neuron, but we typically will call the whole thing together the motor unit. And what we basically have is we have these efferents that are carrying signals up to the neuromuscular junction, and depending on which type of motor neuron we're talking about, it may innervate the different muscle spindles differently. We might have innervation of a large group of muscle spindles that can actually control large muscle groups. We can have very small individual muscle spindle innervation where we can fine-tune stretch and contraction. And these are just some things, believe it or not, that we're still learning about. There's still a lot to learn in terms of the physiology and how some of these medications actually work. When we talk about the targets that we're actually thinking about, we have sensory fibers that actually tell us what are our muscles actually doing, how are they contracting, what is their position, etc. The type 1 sensory fibers tend to be more around the stretch and the speed of stretch. The type 1B sensory fibers tend to be more in the speed of the stretch versus the strength of the stretch. And then the type 2 sensory fibers really are more, where are your arms at any given time, or your legs, the muscle proprioception. Have you guys seen Talladega Nights, where he's like, I don't know what to do? Okay, maybe it's too early for my sense of humor. Now, most of us learned that the skeletal muscle relaxants predominantly impact the different types of GABA receptors, or gamma aminobutyric acid receptors. Remember, GABA is our primary inhibitory neurotransmitter in the nervous system. And when we talk about GABA A and GABA B, these are distinctly different receptors, even though they're both called GABA receptors. GABA A are ligand-gated, and GABA B are actually G protein-coupled receptors. So they're going to have completely different downstream physiologic effects. And believe it or not, now, just since we submitted our slides, there has now been identified a GABA C receptor that I was trying this morning at breakfast to read up on, and I didn't get too terribly far. But it exists, so you learned something this morning that is new and cutting edge, I suppose. GABA A tend to be all over the place in the body, whereas GABA B tend to be more localized within the CNS and the brainstem. Both of them operate via hyperpolarization of the inhibitory neurons that they're purporting to affect. GABA A tends to be chloride, whereas GABA B tends to be potassium. There are a gazillion different subtypes of GABA A conformation, as well as different allosteric binding sites. So things like barbiturates operate here, benzodiazepines. We think some of the skeletal muscle relaxants. And so how the different GABA receptors impact inhibitory and excitatory neurotransmission really kind of bears to be seen, because we found that these GABA receptors can be inhibitory or excitatory, believe it or not, depending on where they're expressed. That tends to be the case with GABA A, and it looks like maybe GABA C. However, GABA B receptors always have an inhibitory effect when they are activated. And what's really interesting, so GABA B has not really been around, or our understanding of GABA B really hasn't been around for a very long time. Does anyone know how they actually identified the GABA B receptor? Like, we're going full nerd here. Radio-labeled baclofen. So, we talk about baclofen being a GABA B selective or skeletal muscle relaxant, or a GABA B agonist. However, that's actually how they identified that there was a separate GABA receptor. I thought that was pretty interesting. Dr. Krieshbaum and Moransky did, I think, a really good job yesterday of differentiating between spasmolytic and spasmodic. So spasticity is sustained involuntary muscle contraction, whereas a spasm is sudden involuntary muscle tightening or contraction. So they're really kind of two separate things, and we categorize our drugs separately based on this. I know a lot of us will say skeletal muscle relaxants within one larger group. However, we tend to try to differentiate those based on what their actual pharmacologic action are. And if it's okay with you all, I'd like to go through these individual drugs with the exception of dantrolene and onabotulinum toxin, just because we obviously don't see dantrolene used as a skeletal muscle relaxant. That's more neuroleptic malignant syndrome or malignant hyperthermia. But the onabotulinum toxin as a skeletal muscle relaxant, I think we all recognize that it works in that role. I think that where we should be using it is really still left to be said. How many people in here do the Botox injections for the migraines? Okay. And how many of you all just throw the extra 40, 45 units away after you do it? Where do you put it? So if you're not willing to share where you put it, we need you to write these experiences up, because everybody that I know will cheat a couple units here in the neck, or maybe a couple here in the paraspinals, but we don't have good data to actually support what we're doing. I'm not arguing with you. I've seen it work. We need to be able to move this conversation a little bit more into the mainstream. Sound fair? Okay, let's rock. So we're gonna get into the meds. Now, I'll do my very best to try to differentiate when some of these mechanism pharmacology discussions are human versus animal. All of the real data is being handled by the much better half of this presentation crew afterwards, and I believe all of yours is human. So I get stuck with the mice and the rats, I guess. First and foremost is baclofen. Tried and true, I think if you're here, you probably have used baclofen in your practice before. It's a very interesting medication. There's a pretty wide dosing range for oral. Intrathecally delivered baclofen, I think, has made some really huge impacts on the quality of life for patients with contractures or ongoing spasticity. Some things that we do need to keep in mind with this drug: it does require renal dosing. Its half-life tends not to really jive with how we dose it traditionally, and we need to be really careful about abrupt discontinuation. Now, we know that abrupt discontinuation when somebody is on an intrathecal pump with baclofen can be really serious and potentially fatal. The abrupt discontinuation of higher oral doses really hasn't been spelled out great in the literature, but I always take the position of caution and wean baclofen when I'm up above 60 milligrams a day down to hopefully no more than 10 to 15 milligrams a day before we abruptly discontinue it. One thing that you need to put in your mental Rolodex or your pharmacology Rolodex is that any patients that have or have had a history of absence seizures should avoid this drug like the plague. And its mechanism of action is super interesting to me. Okay, so what we know, and most of this is based on animal studies, patch clamp studies, things like that, is that it is a GABA B selective agonist. So it does not impact GABA A, only GABA B. So we tend to see a little bit less, at least clinically, sedation with this drug compared to some of the other traditional medications. The other thing that's super duper cool about this drug is that it's also a voltage-gated calcium channel alpha 2 delta antagonist. Does anybody know what other drugs have that mechanism of action? The gabapentinoids, right? Pretty cool? Come on, you guys got to get more excited than this. Really cool. Thank you, Maria. Very cool. I know. Okay. I do put diazepam in here as a skeletal muscle relaxant. However, all the benzodiazepines really should be considered skeletal muscle relaxants, and they're all fairly good skeletal muscle relaxants at that. However, obviously, there's some baggage with these medications that we're all fairly well aware of. Very rarely do we use these in practice. I think some of our local neurosurgeons will put patients on diazepam or similar right after some of the ortho spine surgeries that they conduct. We really got to be careful with this particular medication for a number of different reasons. One, we do need to monitor periodic liver transaminases. If you are using diazepam in your practice from a pain standpoint, and I'm not saying that's a bad idea, but you do need to make sure that you realize that when you're doing risk mitigation with this drug, you expect to find oxazepam and temazepam as metabolites on your drug screens. If you don't, then there's probably some concern that there might be diazepam being used for other purposes by other people than who you are prescribing it to. Please avoid this in significant hepatic dysfunction. We do need to wean diazepam, obviously, as a benzodiazepine, and this is a GABA A agonist, right? And it's specifically at the benzodiazepine binding site. I think Mandy and I's other favorite skeletal muscle relaxant, as I'm sure probably a lot of you as well, is tizanidine. Tizanidine is a very interesting medication. It's available in a ton of different doses in terms of tablet strength. The other issue is that we can move this drug up pretty high. I think that the max that we've used it and it's been successfully tolerated was up to 32 milligrams. And we have a few patients that can tolerate getting up that high, but we don't frequently go that high. You do need to renally and hepatically dose this medication. We're supposed to get baseline serum creatinine and liver transaminases. And then the other issue is that they recommend, because of some signs of elevated ALTs, even at normal doses, that we need to be doing periodic transaminase monitoring with this medication as well. However, I don't know really what periodic means. Does anyone else use tizanidine in here in their practice? Lots of hands. How many of you all monitor transaminases with it? A lot of hands. Monthly? 6 months? Annually, I see some 6 months, some annually. So we just did a consensus guideline, right? There you go. It is metabolized via CYP1A2, so you have to be careful with some of the 1A2 inhibitors with this medication, as well as remember smoking can induce CYP1A2, depending on how you smoke. If you're like a binge smoker, I think it inhibits it. I can't remember all of that. Just don't smoke. That's the moral of the story. Very interesting mechanism of action with this drug. It's thought to have presynaptic motor neuron inhibition primarily via GABA A, and it is also a centrally acting alpha-2 agonist, similar to clonidine, guanfacine. There's a newer medicine out that we use for opioid withdrawal called lofexidine. And so what we're actually starting to see with tizanidine is that a lot of our medically supervised opioid withdrawal or medically supervised withdrawal centers in our area at least are replacing clonidine with higher dose tizanidine to try to hit both the muscle cramping and some of the noradrenergically mediated side effects. So super cool. However, just like clonidine and guanfacine, you do got to pay attention to potential blood pressure lowering effects of this medication. And if you abruptly discontinue it, rebound hypertension, right? Fair enough? Okay. Another cool thing about tizanidine is that it also has really good evidence, I can't remember if you talk about this or not, in prevention of cervicogenic headache. And so I'm starting to see a lot of our headache specialists in our area turn to tizanidine, not as a PRN drug, but as something routinely used for prevention. And that's going to get me on a soapbox as well, kind of going off on a tangent, is I wonder if we're actually using these drugs correctly in our practice by dosing them PRN, as we start to think about some of these different mechanisms of action that I'm showing you. We have carisoprodol, brand name is Soma. You all have probably been taught over the last 10 years or so that you should never, ever prescribe this drug ever, right? And I'd like to be somewhat controversial. How many of you all have had a patient come in and say, Soma is the only muscle relaxant that works for me? Keep your hands up. Now look around. Okay, so now, of those hands that were up, how many of you all believe that your patients were trying to manipulate you, or that maybe they actually had benefit from that particular medicine? No hands? Thank you. Well, so the problem was we found that there was this trinity, they called it the holy trinity of terrible prescribing back when the opioid epidemic really started, and it was opioid and a benzodiazepine and carisoprodol. And when you look at the way that benzodiazepines and carisoprodol actually bind GABA A, it makes sense, because the barbiturate or meparbamate that this drug is metabolized to actually potentiates benzodiazepine binding and the downstream output of these GABA receptors. However, my big question is if this was the only controlled substance that you were giving a patient, it was this and ibuprofen, would you be as worried about providing it? And so, I don't know. Has the pendulum swung too far? Do we want this drug to go the way of Darvocet and now soon to be codeine, where we get it taken off formularies and we can't get it anymore, and then it's pulled from the market? I don't know. Just something to, I don't mean to be preachy, but that will likely come if we don't have a reasonable place to use this medication. We don't use a ton of it unless it is the only controlled substance, and it's this or moving to an opioid. Because at that point in time, I feel like it's the lesser of two evils. Fair enough? Okay. Don't abruptly discontinue this drug for obvious reasons. It can cause seizures. Assume carisoprodol is a barbiturate. And you will also probably see a positive barbiturate screen on your urine drug screens if you do choose to use this medication. It looks like a GABA-A drug. It may have some other mechanisms of action, but it really hasn't been studied very well because of this unspoken moratorium that's been placed on it. Moving on to chlorzoxazone, another very interesting medication. We really don't know how it works. If you look it up, it says does stuff with reflexes and interneurons, but it doesn't really give you any specific stuff per se. Chlorzoxazone kind of fell off of the preferred muscle relaxant list probably between 15 and 20 years ago when we started to really see increasing reports of potential hepatotoxicity with this medication. I tend to find that my patients struggle to tolerate this drug from a sedation standpoint. It does recommend that we do both baseline serum creatinine and transaminase monitoring, and we also need to be careful using this medication in absence as well. The interesting thing about chlorzoxazone, again, this is some kind of late-breaking stuff, is that there is a research group, and I want to say that they're out of Stanford, but I'm not positive, and they are investigating a couple of these skeletal muscle relaxants in terms of their effects on neuroinflammation in Alzheimer's disease models. Okay, and so really what I thought with some of the studies that they're doing specifically in murine animal models is that what they're finding with chlorzoxazone and some of the others that I'll mention here in a minute is that chlorzoxazone actually demonstrates an inhibition of glial cell activation, so that obviously has some potential impact in chronic pain. They found statistically significant reductions in expression of TNF-alpha and interleukin-1b. And what's really interesting with this is that this may start to make you be thinking maybe this is a medication if tolerated and that we can use it routinely and not in a PRN basis. It may have some disease modifying effects. So I think that that's super interesting. How am I doing on time? Am I cutting in? Okay. Well, do we need to talk about cyclobenzaprine? I mean, it's essentially a tricyclic antidepressant, so you can expect both the same mechanisms of action as well as the same adverse effects, anticholinergic, sedation, QT prolongation. It has a number of contraindications and drug interactions that we need to be aware of. I'll tell you that the only time I personally start cyclobenzaprine, usually because we're a primary care referral service, people come to us on this medication and then we change them to something else. But when we start it, we're starting it primarily for patients with fibromyalgia disorder, and we're dosing it differently. We don't do PRN, we don't do 10 milligrams Q8, but we follow the evidence and we dose it either 5 to 10 milligrams in the morning and 20 milligrams at bedtime, which, depending on where you all practice, is how your patients are essentially taking it anyway, regardless of how you prescribe it. Agreed? Okay. How are we doing? Are we having the same sedative effect as cyclobenzaprine at this point? You guys all awake? Okay. So the question is, can I tell a difference, 5 versus 10? In terms of efficacy or side effects? Good question. I would say that we go with 10, and then if they are unable to tolerate the 10, then we pull them down to the 5. And, it's really tough to get patients that are suffering from fibromyalgia disorder that have failed a million other medications, sometimes including cyclobenzaprine dosed inappropriately before, to come back to the fold and to try it routinely around the clock like that. Now, we could assume that the secondary amine tricyclic antidepressants might have a very similar impact if we were to dose them that way, but the data is not there to really support it. Another medication I want to talk about is metaxalone. This is not one that you see typically used, but if you remember when this medication first came out and it was named brand, its claim to fame was it was the least sedating skeletal muscle relaxant. And then most of us, including our patients, came to find out that it's also probably the least effective skeletal muscle relaxant. However, again, this drug was included in some of these Alzheimer's disease trials, and what we found is it has some other mechanisms of action that we didn't know about, including monoamine oxidase A inhibition, decreased NF TNF alpha and interleukin 6 concentrations increased PPAR gamma and decreased other surrogate markers of neuroinflammation. So again, where that really puts this in terms of what should we be using this drug for, I think probably where it really boils down to is these should really be considered opioid-sparing medications in the chronic pain population. And by sparing, that either means decreased doses or avoidance altogether if you can. It's another tool before we get to kind of the end of the road. Methocarbamol is another very commonly used medication. It looks very similar to guaifenesin, so I don't know how many of you all have ever heard from a patient with fibromyalgia or chronic myofascial pain syndrome that they use high-dose guaifenesin. They heard it in a chat room or something like that, and they'll swear that this works. There's data to prove otherwise. However, a lot of your patients are doing this. And the thought is because of potentially guaifenesin's muscle relaxant effects. Methocarbamol is kind of an on and off again drug for us. Sometimes we have difficulty getting it from local wholesalers, and then our patients will call us and need to be switched. It does cause your urine to do some pretty funky stuff. That can be distressing or fun. I don't, whatever you think that looks. It can cause your urine to turn green, blue. It's like Skittles. Methocarbamol is another interesting way of looking at it in terms of what we have going on. Again, this is like brand new studies, but there was a study published probably about 6 months ago, maybe 4, that really came into print after being published ahead of print, showing that methocarbamol, when given with morphine, statistically significantly reduced morphine requirements in a postoperative setting. And then the other thing is methocarbamol was also included in this group of trials looking at Alzheimer's disease, neuroplasticity, and neuroinflammation. And what they found with methocarbamol is that it is a selective sodium channel 1.4 antagonist. And believe it or not, those are the sodium channel subtypes that are predominantly localized in intrafusal muscle spindle fibers. So I feel like we're just, we've kind of poo-pooed these drugs for years. Oh, we don't have any data, and they don't work, and they're just make you sleepy. But we may be finding some really cool science behind these drugs as we peel the onion back a little bit more. Orphenadrine is my new favorite. Even though it's probably the oldest skeletal muscle relaxant we have. Orphenadrine was actually originally released as an analgesic. It didn't take off, and so then they rebranded it. You can get it either as orphenadrine, as a sustained release product, or you can get it in combination with aspirin and caffeine. It's a really interesting drug in that it has some really unique mechanisms of action. It does have a lot of anticholinergic and antihistaminergic effects, so pretty much anyone my age or older in my patient population is not able to tolerate it. That young. And the other thing that makes it really interesting is it's a sodium channel antagonist, non-selective. It's a norepinephrine transporter protein inhibitor, and yes, it has NMDA glutamate antagonism associated with it as well. So what we've been trying to do is when we're trying to get a disease-modifying effect in our patients, we've been trying to do this lower dosing than recommended, see if we can get it on board. Unfortunately, I would say 3/4 of the patients that we trial it in can't tolerate it because of the typical anticholinergic side effects: constipation, dry mouth, dry eyes, can't see, can't spit, can't pee, can't. You guys can rhyme the rest of that, right? Okay. So with that said, I think that if I can just quickly share my soapbox of skeletal muscle relaxants, I think that the data is questionable. We as a profession still don't know where these drugs truly fit into practice. And I think that probably as we continue to look at them, investigate them, I think we've been barking up the wrong tree. I think all of these failed acute pain studies were done in when we should have actually been doing this in more of a chronic pain, long-term, around-the-clock dosing at lower doses than what's typically used. So with that, I will turn it over to my esteemed colleague, Dr. Mullins.
Nice job. So as Chris has been what are we at, 20
Yammering.
minutes? Yeah, talking the last however many minutes about, the potential benefits of some of these medications. As he did also mention, we do not really have that evidence to back it up right now. And we'll kind of go through, maybe some of the reasons why and, what we can do in the future to improve that. So the first thing I wanted to start off with is this drug approval slide. And so as he just mentioned, orphanidrine, probably the oldest. You can see on here that it's not the oldest per the timeline. That's kind of got some wacky font things going on, so apologies about that. But the newest agent is actually tizanidine. And so that was approved by the FDA in 1996. So it has been since 1996 that we have had a new muscle relaxant, brought on the market. You can see that methocarbamol, chlorzoxazone, carisoprodol or soma, orphanidrine, and metaxalone were all actually approved by the FDA before the Kefauver-Harris Amendment in 1962. So if you remember what this amendment did, is it actually, expanded the legislation to say that those manufacturers have to prove both safety and efficacy, before something can be approved for use in humans. And so, not to say that those don't work or that they're not safe, but just a caveat that they were approved, before really the FDA was looking that hard at them. So when we talk about FDA-approved indications, Chris did mention kind of the difference, between spasticity and then your spasms. And so that is something to keep in mind. You will see some of the medications kind of be used for both types of conditions, namely tizanidine, sometimes baclofen. But, your examples of your spasticity conditions are your multiple sclerosis, spinal cord injury, cerebral palsy, things of that nature. Looking at medication specific for that, you will see more of that dantrolene use in that patient population, along with, again, that baclofen, I think, which we all assume, and then also that tizanidine. For our spasms, so examples include low back pain and then arguably, that component of fibromyalgia. You're looking at pretty much all of your other skeletal muscle relaxants kind of fall into that category. And I think it's important to, point out the differences in these indications, because that's how a lot of the guidelines are also breaking it down, is based on either spasticity or spasms. So we are going to just dive headfirst into the existing evidence. If any of you guys have ever gone down the rabbit hole of data surrounding muscle relaxant use, I'm going to say you can pretty much find any standpoint that you want, because every standpoint exists. They're beneficial, they're not beneficial, they're safe, they're not safe. You can pretty much find anything to argue the point that you want. So I did my best to put it in very, very simple terms, in bullet points. So let's go through it. The existing evidence, there are a ton of trials. So it's not finding some data. The data is easy to find, but the quality of that data is what is a little bit subpar. So if you look, there are meta-analyses, there are head-to-head trials comparing, one agent to the other, which we don't always get. There are placebo-controlled trials, there's observational studies. Again, these are at best fair quality, most are poor quality when you're really looking at these studies. A lot of them are single center studies, and so we know, the bias that comes with that. Small sample sizes, you name it. A lot of the times, they're not reporting on any of the adverse events that these patients are experiencing. And p-values are often not reported. So it's really, the author saying, this is what we think, but we're not going to tell you why. And so even through all these trials, there's really no strong evidence that, one agent is superior or better than any of the others. Okay, so diving into efficacy. So we're going to talk about efficacy of different agents over the next couple of slides. And then again, we're breaking it down into spasticity versus spasms. So we're first going to look at spasticity. There are some comparative trials out there, so head-to-head trials of one agent versus another. One of them was looking at tizanidine and baclofen, and this study found that they were similarly efficacious, fair, again, at best, quality of evidence. There was another study comparing tizanidine, baclofen, and dantrolene, and it found that all of these were similar to diazepam. So now you're like, okay, well, I guess my options just expanded a little bit. And again, fair quality at best. And then dantrolene versus tizanidine or baclofen, and they didn't really say much on that one. As you can see, it was a poor quality study, and I think, that's a safe assumption. So then looking at efficacy of different agents versus placebo, they did find that tizanidine, baclofen, and dantrolene were all better than placebo. So maybe they work better than placebo, but we don't know which one works better than the other. Again, fair quality of that study. So looking at musculoskeletal conditions or more of your spasms in that patient population, there are some comparative studies out there, namely looking at cyclobenzaprine and diazepam, and again, fair quality you can see, and those are found to be similarly efficacious. The next one is interesting because Chris and I did get into the weeds a little bit about whether carisoprodol or soma should be prescribed if you do have someone coming in and saying that is the only thing that works for them and they're not on opioids or benzos or anything else. And it was found that it was actually possibly superior to diazepam. Again, poor quality study, kind of a toss-up of why they compared it. Diazepam, I guess they were going for controlled substances, which one's better? But again, poor quality, possibly superior. So versus placebo, you can see that cyclobenzaprine, carisoprodol, orphenadrine, and tizanidine have all shown to be superior to placebo. And then methocarbamol, metaxalone, dantrolene, chlorzoxazone, this is a mouthful, and baclofen, all superior to placebo. However, poor quality, again, in that study. So all to be taken with a grain of salt. Most recently, there was an article that was published. It was a randomized double-blind placebo-controlled trial of naproxen with or without orphenadrine or methocarbamol for acute low back pain. So this was in patients that were presenting to the emergency department, in this trial that had non-traumatic, acute, non-radicular low back pain. And so that was the specific patient population that they drilled this down to. I don't know how many of your guys' low back pain patients are non-radicular, but mine probably lean the other way more heavily. So that already, in my patient population is not really extrapolated. Anyway, so they found actually no difference, that adding these muscle relaxers onto naproxen for this patient population was no different than naproxen plus placebo. So kind of flipping the switch a little bit on your pro side. It's like an unofficial debate. Okay, so now we're going to dive into the safety as evidence. And so again, looking at spasticity first, tizanidine was shown to have lower rates of weakness compared with baclofen. However, it does, as Chris mentioned, have that risk of hepatotoxicity or elevation in the liver transaminases. And so that can be asymptomatic, which can be a little concerning. Baclofen had lower rates of dry mouth compared with tizanidine, and if you're all thinking, okay, great, that's about what I think too. And then dantrolene, of course, we know has serious hepatotoxicity concerns. For musculoskeletal conditions specifically, and this is how they were all studied. So tizanidine, in a spasms study, had different findings than tizanidine in a spasticity study. So reversible hepatotoxicity again, and then chlorzoxazone with the reversal hepatotoxicity. Okay, so most recently, I think we're all aware of, the newer recommendation to either prescribe naloxone or, not prescribe skeletal muscle relaxants if someone's on opioids, not just soma, but really any of them for that risk of respiratory depression, for that additive CNS depression effect. So they actually found in this article that baclofen was kind of the #1 culprit of any overdose-related concerns with muscle relaxers used in combination with opioids. So I thought that was interesting. Chris is a baclofen fan, apparently. So in other words, trying to, again, make this as simple and as simplified as possible. If you're looking at spasticity, the most studied indication or condition is multiple sclerosis. And they recommend really tizanidine and baclofen, either or. They pretty much find that they're similarly efficacious in that patient population. When you look at your musculoskeletal conditions, namely low back pain, which I think is what most of us probably see most often, you're looking at moderately effective agents, and those include carisoprodol, which we can assume is not being used that much, cyclobenzaprine, and then tizanidine. Okay, so where do these come in therapy? If you guys have ever, I don't know, looked into the guidelines about muscle relaxants, there's a million different guidelines out there, right? Every kind of organization has their own thoughts on where these go. And so we're going to just run through them very briefly, and then we'll talk about, kind of picking one in your clinical practice after that. So for musculoskeletal pain, the assessment and management of chronic pain guidelines recommend as adjunct therapy for fibro specifically to consider cyclobenzaprine. And I think Chris laid out, why that could be beneficial in those patients or in that patient population. And then for neuropathy, they actually have a loose recommendation to consider baclofen if needed. So not something that you're going to prescribe first, over some of your other neuropathic pain medications, but something if you're at the end of the road, you might need to consider. In the diagnosis and treatment of low back pain guidelines, they do say you can consider skeletal muscle relaxants second line after failure of Tylenol or NSAIDs. For acute back pain, they recommend all except baclofen and dantrolene. So you can kind of see from even the evidence that we presented where baclofen was on there, with maybe some fair quality evidence that it's not making its way in this guideline at least. The occupational medicine practice guidelines for cervical and thoracic spine disorders recommend, any of the muscle relaxants second line after failure of NSAIDs. And then for shoulder disorders, they recommend second line after failure of Tylenol, NSAIDs, or other measures, undefined. Try other things. Yeah, PT, try other things. The guideline for evidence-informed primary care management of low back pain recommends cyclobenzaprine specifically as adjunct therapy to a first or second line therapy. So don't try it first, but try one or two things, and if you need to add on cyclobenzaprine, that's the recommendation. So the evidence-based management of acute musculoskeletal pain, I found this interesting, does not recommend any of the skeletal muscle relaxants, really just due to their side effect profile. I guess not worth it in their mind with a little sedation or hepatotoxicity, that wouldn't be good. But the traumatic brain injury or TBI medical treatment guidelines recommend against carisoprodol or soma because of the metabolite, and that's not an opioid metabolite, so you guys can ignore that. Okay, and then the spasticity associated with multiple sclerosis. Again, this is probably, the best guideline that exists surrounding skeletal muscle relaxants because it is the most studied indication. It's kind of, we have the most evidence for our spasticity conditions. First line, they actually do recommend baclofen over tizanidine, and then second line to consider tizanidine or dantrolene. Have you ever seen dantrolene used?
Not outside of NMS.
Right, for spasticity. Okay.
I haven't.
Yeah, me neither. Okay, so we're almost done with these guidelines. Hang in there. So the spasticity associated with upper motor neuron lesion disorders, which is the guideline, has the most data actually in children and adolescents, so a little bit different of a patient population, but very much needed and very helpful. With non-progressive brain disorders, they're specifically recommending baclofen. I feel like baclofen's the winner in a lot of these. And then for spasticity in children and adolescents with cerebral palsy, again, a very interesting patient population, they recommend tizanidine, so a little bit different. And then the European Federation of Neurological Societies guidelines on clinical management of ALS, so now looking at ALS, they are recommending baclofen specifically second line after completion of physical therapy. Okay, so let's talk about, after all of that information, putting those question marks into words, and how do we actually then, if we're ready to prescribe a muscle relaxant, how do we choose? So things to consider are available evidence, which you guys know is pretty much meh. Any comorbidities that that patient has, side effect profile, and then, of course, drug interactions and metabolism. So this is a nice little table that has, the most common possible side effects listed, and then any clinical pearls for, that specific agent. So you look at all of them, again, a little wonky formatting, sorry. But you can see, different things to consider. So, if you do have somebody, the biggest thing I think about is, drug interactions or other medications that can cause, right, elevation in your liver transaminases. Maybe you want to avoid something that we know can cause, hepatotoxicity or just further that increase. For the sake of time, we will just, this is available for download. If you want it, you can take it, but we will move on. So just briefly looking at metabolism, this is just some examples of how our, some of our different muscle relaxants are metabolized. And so you do think about, genetics, right? And your poor metabolizers and your ultra rapid metabolizers and how that can play in with each of these. And then you also look at, the substrates, of course, of the different enzymes. So cyclobenzaprine and tizanidine are metabolized by CYP1A2. And so, that's important to know. Of course, drug interactions, any substance that's going to inhibit or induce any of these enzymes is going to be, you've got to take that into consideration. And then there also is some data that tizanidine actually inhibits 2D6 a little bit as well. And so that's something to, keep in mind whenever you're prescribing tizanidine, because what are a lot of our other medications metabolized by, 2D6, right? Okay, so here's some more charts, or tables, I guess, tables for everybody. Really going over inducers, are they strong, moderate, weak? Most commonly, we have the same thing for inhibitors. And then the next, this is actually mislabeled because then this table changes into, different substrates for those enzymes as well. So here's your substrates, again, your inducers, inhibitors, kind of all in one place. And then that's continued. So here's some vital points. You'll see the scale on the right with the arrow. This is something anecdotally that I have seen in my practice for fun because Chris introduced me to ChatGPT this week. I had never used it before. I sat in my room last night and I asked ChatGPT what was the most sedating skeletal muscle relaxant. And at first they actually came up with baclofen. Yeah, nice. I know. And then I asked it again this morning, and it said maybe cyclobenzaprine. So even he doesn't know. She, ChatGPT does not know. But anyway, I did then ask the lease, and it actually said metaxalone, which made me laugh because of your viewpoints.
I swear I didn't do my part from ChatGPT.
We'll never know. We'll never know. But you do want to monitor for drowsiness and sedation in pretty much any skeletal muscle relaxant use, in any patient. Most of your muscle relaxants can cause an increase in those LFTs. I pretty much, whenever I had my residents and students, would tell them just assume that it does. There are a select few that don't, and that's easier to memorize than which ones do. So again, they may have additive effects in respiratory depression when used in combination with other medications that have, the CNS depression risk. So just keep that in mind. And then again, anecdotally, I find the most tolerability concerns with cyclobenzaprine. Usually they're on a myriad of different medications and they just can't have another. That causes that side effect. Methocarbamol is something that we often use because we don't see a whole lot of tolerability concern with it. And even sometimes we do methocarbamol during the day and then have them take their cyclobenzaprine at night. And
You guys do that too?
yeah. Do you do that? Did I learn that from you?
No?
Who knows? Who's to say? All right, and with that, we have, I think, a minute left if anybody has any questions. There is a microphone over here, or you can yell. Either one. Or you can come up.
Dr. Mullins, what do you think about the data looking at medical cannabis and spasticity. Should we be counting cannabis as a skeletal muscle relaxant?
I think the evidence would probably be the same quality as the current evidence on the muscle relaxers.
Yeah.
So I'm a pain clinician in the hospital, and I recently got consulted on a patient that was taking high-dose baclofen. I don't remember.
Oral or pump?
Oral.
Okay.
Okay, but was sedated, intubated. So how do you treat those? Because they were like, what do we do? And I'm like, oh. So I looked, and there's like no guidelines what to do. I asked our PM&R. They're like,